Welcome to the Crescent City, where Vital Options is in New Orleans with ASH, the American Society of Hematology. With every cancer type, there are different side effects related to their therapies. Let's first talk about some of the common side effects that palliative medicine needs to address for hematologic disease.
Well, that's an area where we don't know as much as we need to know, unfortunately. So the available evidence is relatively limited, and part of what I'm trying to do with my research focus is to first describe what the burden is. What are the most common symptoms with all the different types of leukemias and lymphomas and across the various types of treatments? And as you heard earlier, there are literally dozens and dozens of types of even just non-Hodgkin lymphoma, and that's just one part of the hematologic malignancies world. So really we have a ton of descriptive work to do before we can really apply evidence-based interventions, but yet there are certain things that probably anecdotally, oncologists who practice hematologic malignancies would say they see a lot of. And it's things that sometimes are actually quite difficult to treat, like fatigue. There's probably not as much pain in the hematologic malignancy setting. Some with lymphoma and myeloma, certainly not as much with leukemia. It might be something like anorexia, just not having an appetite, cachexia, losing lots of weight, which can be very distressing to patients and families. But another actually is probably anxiety, not knowing what the future holds, knowing one might be in the hospital for a long period of time. It's very difficult for patients and families to go through. And these are things that we really struggle to address, and frankly we need to be figuring out how to do a better job at.
Do these patients deal with secondary, perhaps skin issues, rashes, losing fingernails, toenails? Do the therapies for the blood cancers, like in the solid tumors, are some of those common reactions?
Some of them are. A lot of the skin issues come up with some of the newer targeted therapies, a lot of which are oral medications that patients are taking as an outpatient. We don't have as much of those things in the hematologic malignancy setting. A lot of what we're using actually is still traditional cytotoxic chemotherapies, older chemotherapies. So many of the toxicities associated with those are the more traditional ones related to things like nerve damage, tingling and numbness in the fingertips and toes.
Neuropathy.
Neuropathy, exactly. It's a major problem, especially in multiple myeloma with some of the agents that are very effective that we're commonly using, but that's a severe dose-limiting toxicity.
Meghan and Scott, some of the issues I know we've had with patients is the reluctance to maybe talk about some of their side effects for fear maybe my treatment will be reduced or my dosing, or I don't want to look like I'm complaining. There are many reasons why maybe people will withhold some information. Tell us what you hear from patients, and then maybe Dr. LeBlanc can talk about some of these barriers of communication.
Absolutely. So one of the things that we have heard from the patients, we serve at the Lymphoma Research Foundation, is that cancer care planning can allow physician and the patients to actually speak about their goals for treatment, which may seem very simple. We obviously want to cure disease. We want a patient to reach remission. Those are the very basic goals. But a cancer care plan can also serve as a platform for a conversation about quality of life. What are their expectations regarding treatment side effects, short and long-term effects, not only while a patient is in active treatment, which is a very important piece of the conversation, but once they reach post-treatment survivorship. You'll probably recall in its groundbreaking 2006 report, Lost in Transition, the Institute of Medicine recommended that cancer patients receive an updated cancer care plan at that point of survivorship so that they know what to expect in the long term after their treatment concludes. And particularly in a disease type like lymphoma, which is notorious for recurrence, it also sets up that important conversation about what a patient's entire journey with lymphoma may look like. And so again, I think a cancer care plan can be an integral piece of that conversation to manage a patient's expectations, and also for a care provider to understand what a patient's expectations and goals may be for treatment.
The work certainly that LRF has done around cancer care planning, I mean, I think is something that we want to support at LLS because, you know, it is so critical for expectation setting, and it's really a part of an interesting conversation that's important for patients and physicians to have, because what we hear from our patients as well, you know, we want to make sure they have access to quality, affordable, coordinated care. It's not always as well coordinated as you would like, and there's often a disconnect between the physician's perspective of how well coordinated it is, or what side effects the patient might be experiencing, and the patient's own experience around that. So this discussion that is fostered out of that planning, and that just the beginning of that rapport between the physician and the patient is so important to say, let's get on the same page for what our joint expectations may be, because sometimes then the patient come back and say, I thought we agreed, and maybe, you know, I'm experiencing a little more than I thought we had talked about, and it's just a great tool, so I would absolutely support it.
Thank you to all three of you for bringing perspective to this really vital subject.
Thank you.
Thank
Thanks
you.
for having me.
Pleasure.